Hey everyone, welcome back. Let's discuss Candida, which we have gone over on the show before, but today I wanted to do one more pass through. There's always more to learn, and if we can be more precise with how we understand and treat Candida, then we can have improved health with less time, less effort, less testing, less supplementation, and less food restriction. So today what I wanted to do was walk through a number of topics, key indicator symptoms, because with many imbalances in the gut, they can present as a fairly broad and seemingly different multi-system presentation. But there can be key indicator symptoms for us to cue in on. We'll cover how common Candida is, why it can be resistant, and then what we can do to make it less resistant, how Candida can impact brain fog and energy levels, testing options, treatment options, including some important caveats regarding die-off reactions, which do seem to be fairly common when treating Candida. Okay, so then to the most important indicator signs. By the way, this is my clinical commentary. I can't say this has been officially documented in a meta-analysis, but nevertheless, it wouldn't be any one of these alone, but the more of these that you see or feel or experience, then the more suspicious regarding Candida I would be. Bloating, fatigue, brain fog, or mental fatigue. Brain fog is more of a I can't think straight, and mental fatigue is more so it's just kind of hard for me to think. My brain feels tired. It's a subtle difference, but there it is in case it's helpful. Cravings for carbohydrates. Now, there's a really important distinction here, which is sometimes when people think cravings, they picture, oh, the person is trying to quit smoking and I gotta have a cigarette. But if you finish lunch or dinner and you're saying, I would just like a little something sweet. I'm not ravenous for it, but I'd like a sugary thing, fruit, coconut water, whatever it is. If you don't feel satisfied until you have something starchy or sweet, or let's say you're shopping and they have samples out and you just can't help yourself but have the sample of a cookie or whatever, that in my view should be looked at as a potential warning sign. When your metabolism is healthy, foods like that shouldn't have allure. And as someone who's lived on both sides of this, I can say when I'm doing things right for my gut health and also for my metabolism, I'll give you an example. I was at dinner the other night. I had zero craving for a slice of bread, even though Perry Steakhouse does have pretty amazing bread that I would often dip in butter and put some salt on it. As I've made some adjustments, I look at that bread with literally zero appeal. So just something to bear in mind. I'm not saying you can't ever have any of these foods, but if you do not feel a neutrality toward these foods, then that could indicate something is amiss metabolically. A few other things would be a white tongue, toenail fungus, recurring vaginal yeast or jock itch, or athlete's foot. So make note of those. The more of those that you experience, the more likely. Also, there are predisposing or risk factors. These include prolonged use of antibiotics. Not to say one course will be a problem, but multiple rounds or for consecutive months or multiple months. Steroid use, meaning immunosuppressive steroids like prednisone. Hormonal birth control. Prolonged use of antacids. A high-carb diet. Alcohol consumption that's a bit excessive. And stress. Again, none of these things in small amounts will be a problem, but we're thinking, what is the aggregate load of these factors when looked at together? And the reason why I say that is I don't want people to think, oh my God, I can never have a sip of alcohol. I could never use an antacid. Not that I'm advocating that per se, but I just don't want to sort of inculcate fear around these things. Alrighty, so then how common is Candida? 75% of women in their reproductive years will have at least one bout of vaginal Candida. Now, one bout is probably not prognostic, but multiple bouts, I think, starts to look more risky. We've discussed many times before the paper by Satish Rao that found about 20% of people with unexplained gastrointestinal symptoms had Candida. Another 20% had Candida plus SIBO, small intestinal bacterial overgrowth. and then another 20% had just SIBO. So maybe 20% in the GI, at least from the one RAW study. And then looking at oral thrush or white tongue, skin candida, like tinea versicolor or versicolor, or toenail fungus, those impact about 10% of the population. So we could say 20, maybe 30-ish% of people could have fungus, just to give you a rough estimation of how prevalent this is. Now, what makes Candida difficult to treat? Candida is a normal part, a commensal member of the microbiome of various cavities, right? Oral, vaginal, digestive. So it's held in check by this ecosystem. When, for whatever reason, the ecosystem goes out of balance, that's when the Candida go from commensal to what's known as opportunistic, meaning they see an opportunity to exploit more niches, and they literally dig in or anchor themselves with these hyphae. And that's what you're seeing in this schematic here, where essentially they drop these little anchors, or they form technically what's known as filaments that connect them into tissue. And this does two things: makes them harder to clear, but also those burrowing filaments trigger the immune response, or more of an immune response, so hence more inflammatory symptoms. And within this same transition to opportunistic, there can be formation of biofilms. Biofilms are essentially a fence that various microbes, not only Candida and fungus, can build over themselves to protect them from the bacteria that might want to police them out, from the immune system, from changes in pH, from antimicrobial herbs, from antifungal medications. And this is what you're seeing here from the journal Fungi. On the left, you're seeing just the yeast form. For those of you just listening, essentially picture a coffee table and you've got a bunch of peas sort of scattered around there, a bunch of small dots. When you go to the hyphal and biofilm form, this looks more like a pile of yarn. It's beautiful that we have this microscopy that can help us see what these fungus can do when the environment becomes more hospitable to fungal overgrowth. Now, the good news here is there are things that can be done, but I just want to explain this for those of you who may say, well, I saw my conventional doctor, maybe it was a GP, maybe it was a GI, gave me fluconazole, helped for a bit. Now I feel like I'm back to where I started, or maybe only a little bit better than baseline. What do I do? Why is this happening? This is part of the reason why. There's some interesting data regarding how fungus can cause fatigue that I think is important to underscore. Why I feel this is relevant and worth underscoring is because so many conditions might cause fatigue. But considering this 2023, given it was an observational study, so it's not going to be the most rigorous, but nevertheless, 800,000 subjects with a prior infection. It could have been Candida or flu or Lyme or Salmonella or others that were diagnosed with any one of these infections. They found in those having a prior Candida infection, this was associated with a 39% risk of chronic fatigue syndrome. An interesting hypothesis by Dr. Mona Morstein is that due to the acetaldehyde that fungus releases, we'll talk about this more in a moment, that requires metabolism of certain vitamins, and therefore high levels of acetaldehyde can decrease B1, thiamine, B2, and iron, amongst a few others. And so it's this secondary nutritional deficiency that might lead to, in part, the chronic fatigue. And there's also data finding higher levels of fungus in those with IBS, in those with IBD, in those with depression, and in those with anxiety. So it's not all theory. We have at least some preliminary data connecting these dots. And by the way, this has been helpful. Please comment. I really enjoy hearing your thoughts, your experiences. And if you wouldn't mind, share this video with one person you think it may help, and also subscribe so you hear more videos from us. Okay, so let's go a little bit deeper into what I mentioned before, the acetaldehyde and some of the other metabolic byproducts Candida produces, which lead to fatigue and brain fog. With acetaldehyde, it's interesting to consider that this is a byproduct of alcohol consumption, which is why, and this goes back to, I believe his name was David Cook, a pivotal fungal book from like the 80s that one can have what's known as drunk brain if they have a fungal overgrowth. In fact, I think he tells one case study about someone who was given a breathalyzer and wasn't considered legally drunk, but there was detectable alcohol on his breath because of a fairly pronounced fungal overgrowth. In any case, the acetaldehyde can be toxic to the brain. It can also assist in formation of biofilm and weaken the intestinal tight junctions, or essentially damage the cells. And there are other compounds produced by fungus, bearing in mind that none of these are meant to be, the devil reincarnate, but too much of these can then be a problem. There's propionic acid, ammonia. In fact, there's some evidence that suggests people who have a really poor tolerance to exercise, it might be because exercise produces ammonia, but so does fungus. So if your baseline of ammonia is high due to fungus, and then you exercise and say, oh boy, I got really tired, I got really foggy, had muscle pain, this might be why. And fungus can also produce uric acid, which David Perlmutter has discussed can be very deleterious for metabolic function. Oxalic acid, so oxalates, and arabinose, all of which, when excessive, might have negative health implications. So then this begs the question, how can I test this? There's pros and cons. What I like about testing categorically is, at least in theory, it can take the guesswork out of this equation and help us say, well, it could be SIBO, Candida, it could be metal toxicity, it could be mold, it could be low levels of testosterone, what have you. How do I know which one? There seems to be so much symptomatic overlap, and my history seems to suggest multiple different hypotheses in terms of why I'm having insert symptoms here. So this is where the testing, I think, has merit. So a stool test might be able to tell us what's going on in the entirety of the GI tract. Because one study actually did find that the frequency of brushing teeth, and therefore improving hygiene of the mouth, that could lead to a 1 to a 10-fold change on stool levels of Candida. So, at least inferentially, a stool test could tell us the health of fungal populations from mouth all the way to colon. However, another study found that 82% of healthy individuals had elevated levels of fungus in their stool testing. So it's hard to derive a ton of definitive information from a stool test. Well, what about antibodies? What about looking in the blood for reactivity against Candida? Also has a lot of merit, and in my opinion, can tell you when the Candida is going to be, or going into a little bit more of an invasive colonization, meaning it's getting deeper in and it's really stimulating the immune system. And my view on this, just my opinion, is that the antibodies might be most demonstrative of small intestinal fungal overgrowth, which cannot be readily tested in clinical practice because, at least at current, the only way to assess this truly is directly sampling from the small intestine, which is very invasive. So there's merit on the one hand to the antibodies. However, counterpoint would be antibodies can stay elevated after an infection is cleared. So we don't know if the antibodies are telling us about a current or a prior infection. And then additionally, there are about 200 different species of Candida. And at current, the antibodies are testing for these individual species and only some of them. Now, not only that, but there are other non-Candida fungal genus like Geotrichum that we really can't fully assess on an antibody profile. Now, maybe you get a few positives and maybe those correlate clinically, but again, the perspective I'm trying to share here is that we can't hang our hat too confidently on antibodies. And then there's also a urine test, diarabinitol, which does have some merit, at least when looking at truly invasive Candida, but it hasn't been validated yet in more of a chronic low-level presentation. So what I'm saying there is we might run the risk of a false positive or a false negative. And while testing is so appealing, consider this one point, that if you get a false positive, meaning the test says you have the thing, but you actually don't, what that can lead to is months of treatment without feeling any better, because you treated something that wasn't actually there due to a false positive. So on the one hand, I appreciate when someone's not feeling well, they really want answers. Get it? But we should be bridled because those false positives, especially, can lead to months of wasted time, resources, treatment, energy, and sometimes frustration and sort of this emotional toll. So, my perspective has always been with fungus and many other issues or disease states we're trying to quantify within the gut, it's part of a clinical diagnosis, meaning you, your symptoms, your history, your response to treatment. These are the most important variables. And the lab work is looked at secondarily to those data points, creating a mosaic that really allows us to give you a prognosis or diagnosis on a probability spectrum and not looking at it and saying, well, it's yes or no, right? You have the test positive or you don't. Very dichotomous, very cut dry. I wish it was that easy, but it's not. The system is complicated. There's different windows. These windows have different levels of predictive validity. So that's the long short on testing. I did want to make one note on estrogen. And this is that, according to one animal study and one in vitro study, that treatment with estrogen or high levels of estrogen can actually make one more resistant to fungal treatment, or it can make fungus worse. Now, this is not to say that you need to have no estrogen in your body, because then a woman or a man would feel terrible. But it's coming back to that Goldilocks principle of estrogen balance. So Candida treatment, the first is diet. And the one point I would put in the board here as an example, 2018 clinical trial, 120 patients with Candida overgrowth in the stool, for what it's worth, plus gastrointestinal symptoms. There's the clinical context. They were treated either with nystatin, a moderately effective antifungal drug. Fluconazole is probably better, but nystatin, okay. Or nystatin plus a Candida diet. Now, the nystatin alone group, 42% resolution rate, meaning they had no Candida on the stool, and most importantly, they had a resolution of their symptoms. But when combining this with diet, the clearance of the stool test and the symptoms jumped from 42% to 85%. So diet, very, very important. I will say one nuance that we've been sort of feeling out, and who knows, maybe I'll change my mind on this in the future, but I think the best way to consider a Candida diet is you want to go as low carb as you tolerably can. To clarify what I mean by carbs, starchy carbs, sugary carbs. So I'm not saying unhealthy, but rice, potatoes, sugary fruits like certain berries that are higher in sugar, mangoes, bananas. Again, not saying they're unhealthy or other sorts of grains, but those will feed, definitionally, fungus. The more compromised someone's system is, my view, is the lower carb they should go. Now, what happens in some cases is when going too low carb, people don't sleep well or they have fatigue. Now, part of that might be that they haven't fully adapted to a lower carb diet, meaning they need to replace the carbs with fat. They could be undercaloried or hypocaloric, or they don't have enough electrolytes, or they haven't given themselves that few days to get through the transition. But nevertheless, this is something that I think a clinician can really help give the context of, okay, where does this person fall on the risk spectrum and how low carb should we be trying to get them to go? But if you're doing this on your own, I would try to go as low carb as you can. And this has been amended in an update we recently made to our Candida diet. But knowing that some people have different metabolic needs and may not be able to thrive low carb, we have left open allotment for some of these starchy and sugary fruits. But just bear that in mind that you want to aim for as low as you can go and then use your experience to sort of titrate your level of carb consumption. Other treatment options would be probiotics. Probably not surprising. We've discussed all the wonderful things that probiotics do. One evidence point, 2019. So this is a meta-analysis summarizing multiple clinical trials, so a very good data point, studying either blends of lactobacillus and bifidobacterium or a healthy fungus, Saccharomyces boulardii. And I'll just read you the quote from these researchers. We are confident in declaring that probiotics can have a beneficial effect on reducing oral Candida count. So this meta-analysis was looking at oral Candida. A 2023 clinical trial in vaginal Candida compared fluconazole or probiotics. And what they found after 1 month was that probiotics were as effective as antifungal medications for vaginal Candida. And there are also in vitro studies that have found probiotics can reduce Candida growth, reduce Candida hyphae, those filaments, and reduce Candida biofilm. So I would definitely encourage you to make part of your treatment protocol probiotics. Antimicrobials. We've shared in the past this table that we've been progressively building over time with these different botanicals or herbs and how they impact Candida growth, Candida hyphae, Candida biofilm. This can be really helpful to personalize to the individual when we suspect they have multiple things going on at once. Like maybe there's Candida, but also SIBO, or Candida plus we're expecting Babesia or suspecting Babesia. So that can help with the fine attunement of these herbs. But did want to share a couple specific studies here. 2015 randomized control trial, again looking at vaginal Candida, garlic tablets, 1,500 milligrams per day. So that's essentially 3 capsules per day. Had a similar efficacy to fluconazole for vaginal Candida. 2023 in vitro study found that 44 different essential oils, think oregano as one example, cinnamon as another, had varying levels of antifungal action. One of the strongest was actually oregano with specific antibiofilm activity. Oregano can be dosed at about 200 to 600 milligrams per day. Garlic, a starting dose of 1,500 milligrams per day. And I did want to also share something newer to us. We did discuss this in a recent podcast, but Horopito, which sells as a brand called Colorex, versus a different antifungal medication. So Horopito is a New Zealand shrub, so an herb, compared to itraconazole. And in this case, they were treating recurrent vaginal Candida, 6 months in each treatment group, and then a 6-month follow-up after stopping treatment. They found that at 12 months, so 6 months of treatment, 6-month post-treatment follow-up, very important because of this condition being recurring, they found that the drug, itraconazole, had a 34% success rate, and Horopito, the herb, had a 66% success rate. So all of these data points make me feel very good about what we specialize in at the clinic, which is herbal medicines. There's a time and a place for both, but I'm very pleased to see a growing body of clinical trial data or meta-analysis data showing us the effectiveness of probiotics, oregano, garlic, botanicals, and others like Horopito. Okay, here is a big one. As we've been getting more precise in separating bacterial overgrowth from fungal overgrowth and tracking patients in the clinic, we're seeing that die-off appears to be much more common with fungal overgrowth or with Candida. This could include, but it's not limited to, headaches, joint aches, joint pain, fatigue, a worsening of gastrointestinal symptoms. Now, this often will only last a few days, but in some cases may last for a few weeks, especially if you're doing what we generally do in the clinic, which is layering a few different treatments successively. Probiotics first, give that a week, then we'll add garlic, give that a week or two, then perhaps we add Horopito. And so you may notice a little bit of this die-off with every successive addition. That's very important because sometimes people will say, oh, I was having a negative reaction, I'm just going to stop. Negative reactions tend to not get better over time. Die-off reactions tend to start within the first, second, or third day, usually, and then by the third, fourth, fifth, or sixth day, they've abated. So keep that in mind. This very likely will happen to some of you who are trying to treat Candida, and it'd be really unfortunate if that scared you away and you didn't have sort of the poise and the paradigm to try to navigate through that cautiously. If you're ever unclear, I think speaking with your healthcare provider who is experienced in this can help take some of the guesswork out of that. We're also going to be doing a piece on specifically die-off and how to navigate it because this is becoming so much more common that we want to have a go-to resource for people. So hoping to have that released within the next couple months. In the clinic, we are screening with, and again, thank you to Dr. Mona Morstein for putting this on our radar, the FRDQ7 This questionnaire was validated by Santelman, if I'm pronouncing his name right. This questionnaire, wonderful in the sense that it predicted response to antifungal therapy. This is ultimately what we're after, right? As cool and scientific as the testing at least seems, it's predominantly valuable if it's going to help you treat yourself or your patients or your doctor treat you more effectively. That's really, in my mind, unless we're talking about doing population screenings for research and trying to understand trends and risk factors, we're talking about at the clinic, at the office, a doctor or a healthcare provider trying to help a patient. We want to know how to use the tools in our arsenal. What will predict this person is going to respond favorably to antifungal therapy? That is what is so nice about the FRDQ7. And we are pairing this and collecting data on a form we've developed and entitled the FRSQ27. What's different about this form is it's designed to track treatment success over time, whereas the FRDQ7 gives you mostly a baseline risk assessment. So these two tools, we're hoping anyway, can be used together to quantify baseline risk and predict success of future treatment, baseline symptoms, and track treatment success over time. So what's, again, nice about this is these things might be able to supplant doing a stool test, a antibody test, and a urine test, of which you could be looking at $1,000 plus to do that assessment, which is all fine and good for those who want that data, who have the money for that data. But one of the big challenges the functional and integrative medical field faces is we can't be asking every patient to drop a few $1,000s just to get in the door. We need to do better. And I think a lot of the paradigm of being very testing centric, sadly, comes from the industry influence of the lab companies. That's all fine and good, but we just need to put that, I think, in better check and perspective and make the clinical diagnosis for most of these things in GI really be the primary data point and the labs are secondary. So then in close, there's a lot that can be done for fungus. I favor, and hopefully this data has compelled you to agree with me, that holistic and natural treatments might be better, are probably better than reductionistic and only using a pharmaceutical alone. They both have their time and their place. They can be used synergistically. Response to treatment, in my opinion, is the most important component to look at. That's where the rubber meets the road. You can't have die-off, so keep your eyes open for that. And if you're floundering and you need help, please feel free to reach out to the clinic. This is what we love to do, and we'll be more than happy to assist you on your path. Alrighty, guys, this is Dr. Ruscio. Until next time.